Doc Hawk, Dork Brain. I would call it a lot of different things. I'm joined on my left by David Brain. Man,
wow.
David Wild. David is our VP of Performance Improvement, and David has been intimately involved with modeling and trying to build forecasts for how we think the coronavirus is going to act here in a local area and throughout Kansas. I thought it'd be a good thing today to have a conversation about where we are around modeling, and we'll get to that and plus our numbers. But we also have Chris Reuter back with Jessica, who are going to talk a little bit about how opening up the hospital has gone as we've started having a little bit more visitation policy for our patients, as well as in both inpatient and outpatient.
Dr. Seitz, good morning. Yes, Chris Reuter joining us. So, Chris, we know that we aren't the only ones here in the metro and surrounding areas that are starting to ease their visitor policy. It's happening here and across the country. Why is that happening? Why do we know that's a good time?
You know, I think we're all learning how to live with this virus in our lives and to do it safely. So what's important for us is to be able to have patients, have visitors, and support with them at the bedside or whatever they're here for. I think it's time to do that. We know we can do that safely.
So this was our first weekend doing that. How did it go? What was the reaction from patients and visitors?
Yeah, I think this weekend went extremely well. I think people are very glad to be able to be back and supporting those that are here for care. Our staff have done a great job in being able to keep it safe, communicating with patients and families. We really had a good weekend.
And can you just remind everybody who may not know what the new visitor policy is?
So our new visitor policy is one visitor per patient per day. The exceptions include patients under the age of 18, where we can have a couple of visitors, and those patients at the end of life certainly will make reasonable accommodations to make sure they can be supported at the end of life. And then in our cancer center locations, one visitor for an exam visit, but for treatment and procedures or infusions, we're limiting still visitors to all of those situations for safety reasons.
Chris Reuter, thank you so much for joining us on this Monday. We appreciate it. Dr. Seitz, I'll send it back to you in the studio.
I'm sure patients are much happier having a family member or a loved one there with them. So thank you. Yeah. All right, Dana, how are the numbers this morning?
I think they're pretty good. You know, we're always happy with fewer and fewer COVID cases. We ended up having 9 over the weekend. Today we have 11, but 6 of those are in the ICU and 2 are on the ventilators. We did have 2 deaths over the weekend as well. So we want as few patients as possible with COVID, but we certainly are preparing for more should they come, with preparing with PPE, with ventilators, with rooms, and with all the drugs needed to keep somebody comfortable who would end up on a ventilator. But as long as we can keep the numbers down, that's a good thing.
Yeah, they are. It is good. And David, the numbers continue to go up across the metropolitan area and across the state of Kansas, and sometimes at an increased rate. Not quite as many people in the hospital, though. Help us understand what's going on in the coronavirus world as far as the disease and how it's acting.
Yeah, so no doubt we are seeing an increase in the number of new cases, or sort of the rate of new cases, and that has led both in the metro and really in the state of Kansas, or across the state of Kansas, to increasing numbers of total positive cases that you've seen. That's been prominent in the news cycle, and I think that is sort of contradictory to the number of patients that we see in the hospital, for example. Although the number of patients that we're seeing in the hospital is a function of a couple of things. It's a function of the number of new cases, and so as that number of new cases goes up, we do bring new people to the hospital, but it's also a function, the number in the hospital on any given day is a function of how long people are staying in the hospital, and that's really related to, do they have coexisting disease? Do they need ICU care? Are they on a ventilator? Those that don't need those things are here for a couple of days. Those who do need those sorts of treatments are here for much, much longer. And as the number of people who are really critically ill has gone down, so has the number of people in the hospital. We're sort of turning over people more often. People come in for 2 or 3 days and go home. And I think there are probably many factors in why that's happening, but I think a good portion of it is due to the fact that those that are coming into the hospital now are younger and have less coexisting disease. So that's probably related to a couple of things. Number one, it's related to the fact that we're not seeing a large number of new nursing home outbreaks.
Yeah.
And number two, we are picking up patients every day who are asymptomatic, who we catch on a screen. So there were 2 more of those yesterday. patients who were admitted to the hospital for some other reason, really didn't have any symptoms that anyone here was concerned about COVID, but because we're screening everyone, we realized we had two positive tests. And so I think those patients also decrease the length of stay, which means we're churning through patients faster. And that trend is actually pretty consistent in most places. So I think it's a combination of those things, but probably most related to the age of people who are presenting.
And so Dana, talk a little bit. There is some belief out there coming out more of Italy and other areas that the virus has shifted a little bit. It's not as lethal. It seems to be milder. Thoughts about that?
Yeah, we certainly addressed this. There have been other reports of that. Again, to be clear, there has been no clinically significant strain change or anything like that. The virus is still out there, and it's not true. We know that from looking at the genetics and the genome of the virus, there have been base pair changes, so single mutations. This is common in all viruses. The main message is that certainly there is no other clinically relevant strain or anything like that going on right now. And I think to David's point, it's really interesting. Initially in China, they thought maybe there was 2.5%, 3% of people who were overall asymptomatic. It could just be that in their experience and what they were able to publish on so far, they just didn't understand the extent of the disease that was actually out in the community. And I think that's one thing to consider. Now, as we see more reports about the United States experience being 30 to 40 to 45% of people asymptomatic.
Yeah, it's a really large number and a little spooky for everybody else to think about. So David,
one caution
please.
to that, though, as you look at those studies, there was a great article over the weekend that sort of summarized all of the literature that had been present, and each of those studies that they referenced had a slightly different definition of symptomatic. And so that 40% asymptomatic was true at the time of testing.
Right.
But if you follow those patients for longer, not nearly that same percentage was completely asymptomatic. Many did have mild symptoms, would not have called them out if they didn't have a positive test. So I'm not discounting that. There are a lot of people out there who don't believe they have this disease because they don't have really bad symptoms, who probably are testing positive and stay very mild like that. But I don't really think...
more pre-symptomatic or asymptomatic either one.
I think it's more pre-symptomatic than asymptomatic. I don't think that half the people that are infected, for example, never develop symptoms.
And we've seen that in other studies with the common coronavirus and other seasonal colds, where they've looked, especially in a couple of New York publications, the definition of asymptomatic is very different, and most people hopefully would just have mild symptoms. But overall, as few people as possible to have severe symptoms and needing critical care is probably the best.
So one other thought I know that you hear out there is that the density in Kansas City is not so bad. The load of virus that comes at you as you get sick is different. Is that making a difference in the disease?
The overall load?
Yeah, so for example, if I have a really intense exposure to somebody to the coronavirus because I'm in close proximity for a longer period of time, I'm on the subway, let's say, versus I just kind of brush past you, or we're just not as close together. Is the type of exposure changing, the load of the exposure changing how sick you get?
I think we do understand that duration is certainly important. Duration that you're with somebody, a close contact is important, because you're obviously going to have more risk of coming into contact with those viruses. As far as the infection itself, theoretically it could take just one infectious viral particle to get into the area where it needs to be, associate with that receptor on the cells, and then start to infect a cell. But certainly we know that more close proximity, so certainly winter or cooler months are very important for seasonal cold viruses. That can help. And again, the duration in confined spaces is certainly going to be an important thing as well.
Yeah, intensity, duration. So David, as you look across the state, some people have talked about, well, gosh, we're just doing more tests, or we're doing more directed tests. So isn't that why we're seeing more positive patients?
So I think the answer there is it depends. Sometimes it is, and sometimes it's not. So when you go in and you test an entire meatpacking plant or prison, for example, on those individual days where you see lots of positive results, absolutely, that's impacting things.
Yeah.
Across the board, if you sort of either take out those blips or smooth those across the course of time and balance them with the percent positive, so the percentage of tests in a given day that are positive, and then sort of understand the cyclical patterns of less testing on the weekends and things like that. I mean, no doubt, the harder you look, the more you find. but our percent positive is not decreasing, which if we said we were just testing more and that was the cause of all this, you would expect to see that a little bit. In fact, over the course of time, although it has gone up and down, especially since late May, the trend of percent positive generally, if you were to draw a trend line, is up.
So talk about what you're saying with the percent positive. What does that really imply?
Yeah.
What does that mean?
So for example, yesterday here in our place, we were at 4.6% positive. That
So
means,
of all the things we tested,
Yep.
4.6% of those.
so we had
people-
109 total tests run yesterday, and 5 of them were positive, and that
Okay.
means 4.6% of all the tests that we did were positive. For many weeks, we were less than 1%. Just to put it in perspective, and we're testing the exact same way as we had comparatively now towards then. So we're testing everyone that comes for surgery, we're testing everyone that comes for cancer care, we're testing everyone that gets admitted through the emergency department exactly the same way. And now our positive rate is higher than it was 3 weeks ago now. So, and that trend is the same, I think, in most places. Maybe not 1% to 5%, because we're a smaller population than the general population. When you're testing people that come into the hospital, 5% is probably not surprising. If you're testing the general population, I don't think it's probably that high right now.
Okay. And do you sense that the hospitalization rate is really 10%? Is that the number we're thinking of? Because we see a lot of the models, or some of our own, are built off a hospitalization rate of 10%. What's your sense?
That's sort of a loaded question.
Yes, it is.
So when we started all of this, right, modeling, this comes back to the difference between modeling and forecasting. When this whole thing started, we didn't know a lot about how the disease really worked. We just knew about the experience out of China, and we were beginning to get information about the experience out of Italy. And we thought, and now I think we've proven, but we thought that the more physical distancing that you could do, the better off you were, the more that would reduce the spread of disease. And so models were sort of built around those things. And yes, some models did say that you could have up to 10% of those who were positive in the hospital. 2 to 11% was the range that sort of was thrown out there by the experts in China and Italy at that point. We modeled scenarios for scenario planning, meaning for emergency preparedness, with a 2% hospitalization, a 4% hospitalization, and a 5% hospitalization. We never modeled 10 here, but some models did. Some of the national models did. It turns out that those numbers, those percentages of hospitalizations, are pretty close on to what we've seen across the state. It's higher in Wyandotte County than in other places, but we sort of would expect that based on age, coexisting disease, access to healthcare, the other things that matter in this equation. So as we look forward and really forecast what we think will happen in the next 2 weeks or 3 weeks or 4 weeks, we're using a smaller hospitalization rate, more consistent with what we're seeing for the population that comes to our hospital. And I think it's really good that that rate's been declining over time, and we use that actual number now. We don't see a scenario in the next month, for example, that says we're concerned that the hospital will be overwhelmed by positive COVID cases. Yes, we expect them to increase in the hospital, but not thousands of admissions over the course of a week or two anytime in the near future.
Yeah. Other thoughts that you might have, Dana?
No, I mean, I think we've been extremely lucky here. We do know what happens. We knew what happened initially in New York. It was bad. Louisiana, Detroit, Chicago. So it could happen. I think we've been extremely lucky for various factors, and we've discussed some of those here. And we certainly, again, continue to prepare for a surge or increase in patients. Hopefully it won't come, and hopefully that hospitalization rate will continue to be low.
And we'll be challenged over the next few weeks, and we'll see what happens also in New York as New York City reopens, because I think that'll be a major testing ground. And with many of the protests out there, a lot of people in the crowds, and drove by a few this weekend. I saw a lot of masks. I was impressed, actually. That was good. And then I think what happens, it will be interesting to compare against the European experience, where they're about 2 weeks ahead of reopening from where we are. Not seeing a huge spike so far, so that'll be interesting. We'll see how that goes. Well, let's open our questions up first to media and see if anybody has anything they would like to ask. Not hearing anything. I bet, Jill, there's always questions from our audience.
Yeah, the community has lots of questions. Joanne asked, the state of Missouri stated no cases were spread from the Lake of the Ozark party. Is that true?
Boy, that's a hard one to believe, David. What do you think, Dana? Guys? Party or parties? Because I think it's ongoing.
Yeah. So this does bring up an interesting point. I should have mentioned this just a little bit when we started off. So, we've historically thought that we would see the peak new infections from some sort of interaction 2 weeks or so, 14 days after that exposure, primarily because the incubation period has been described as being between really 5 and 14 days in most patients. What we actually see in the data, though, is that increases in cases resulting from some sort of party or decrease in cases resulting from some intervention like a stay-at-home order actually really start to have impact 3 weeks later on new cases and peak at 4 weeks. And hospitalizations that we thought would peak at 3 weeks or 4 weeks actually peak at 5 weeks, and deaths peak at 6 or 7. And that's true in our own data. That's true in the 14 counties for the metropolitan area, and that's true throughout the state of Kansas. And we're not really sure about the reasons for that. We've got lots of sort of hypotheses, and we've bantered a bit amongst ourselves about what that might be due to. But I think it just from that perspective, regardless of whether you think it's true that no cases have spread so far, it's too early to know.
Yeah, it is early, and then the parties are ongoing, and you have to make sure everybody's being tested who is at a party or an associate of somebody who's at the party. And I think it's safe to say we haven't seen a ton of hospitalizations from that, at least that we're aware of in Missouri, and not that have come over to Kansas.
Yeah, absolutely.
And the other question, Dana, is there really just that big a difference between being outside and inside? Because those parties were all outside. Let's say it's true. Let's say nothing happens. Well, again, a supposition. But if you had that many people crowded together in a bar in a small space inside, I think our concerns are a lot greater. I think there's more and more we're learning about outside exposure versus inside exposure.
Yeah, I would absolutely agree. I think we've always talked about the spacing, although you aren't spaced in those parties. You're not spaced at the demonstrations. Certainly being inside in that confined area, I think, is much greater a risk than anything. But again, we have seen a college football player that went to a demonstration and was positive. So that is similar to the outside party at the Ozarks or any parties where there's large people congregating. So we know what can happen. And I would echo David's comments about it may just be too early to tell. But I would certainly think it is possible. And again, if you are inside with all those people congregating together, you are definitely at probably greater risk than being outside for sure.
I think as the old guy here who's been practicing in the world of CF with lots of infection control stuff for years and years and years, I think when this story, this virus is finally written, we're going to learn a lot about this concept of intensity of exposure as well as if you are inside or outside. I think we're going to learn that outside is a whole lot better.
Yeah.
I'm not saying go to Arrowhead Stadium just yet. I'm not saying that, please. This is all my own personal suppositions. So, and I live in a perfect world where I'm always right. My wife does not live in that world, however.
Many of us here don't either.
Probably not.
Nancy has a similar question, and this has to do with the hair salon in Springfield where everyone was wearing masks.
Yeah. But that was a little different. Dave, didn't want to take that one?
This was great. Initially, we had heard 90 or 100 people were exposed, maybe by 2. I think one of the hairstylists exposed at least 90 people. At that point, and I haven't re-investigated this, but from what I heard, there were no cases. And I think the important thing to remember is, people are concerned about, I don't need to wear a mask, I'm not sick. Both the stylists and the clients in these instances were both wearing masks, and I think that's very important to note. So I don't know, again, where the investigation has gone from when it was first reported, but certainly on the initial investigation and testing, there hadn't been anybody that was ill or tested positive, so I think that's a great thing. And I think that is good anecdotal or very small number experience of people wearing masks, so source control of the person who was not ill or knew that they were ill, and then the other person as well, the possible.
Not only were they wearing masks, but I think they were doing things like changing the cape each time and making sure the equipment was washed down and wiping down the chairs. I mean, they were doing all the right things to help prevent transmission, which is what we've been preaching for the last 2 months. And so it's good to have your sermons validated from time to time.
Kathy asks, how long can someone be an asymptomatic carrier?
Oh, asymptomatic
good.
carrier, Dana's. I think that can last for quite a while because, you can carry that virus and spread it potentially for around 10 to 12 days.
Yeah, so we always get to the point of asymptomatic versus pre-symptomatic. If we're just talking about purely asymptomatic person, what we are finding is that, number one, if you are probably younger, say under 40, if you are a woman, you probably are going to have more potential to be an asymptomatic person. And in those times, we've also found that the younger, whether it's male or female, who are asymptomatic probably shed the virus for less time than somebody, say, who has to go to the hospital or who is critically ill. And that is probably around 8 or 9 days, maybe 10 days. Again, we're still learning more and more about the molecular aspects of this, but certainly you're going to be have a less time of being infectious. Now, you could still have it detected on the PCR test. We know that can be detected for a long time. But how infectious are you? Probably not as infectious, especially if you're not ill enough to seek treatment. You'll probably clear the virus a lot quicker.
You know, over the weekend, there was a lot of talk in the epidemiological and modeling sort of circles about this new variable in the equation of how do you understand who's infected and who's not, and they're calling it K. It doesn't matter what they call it, but the point there is that, what percentage of those that are positive are actually, I'll use the term super spreaders for lack of a better term, that some people, the general concept is some people spread more than others, whether they are asymptomatic or not. And it's pretty clear in that it's not related to a change in the virus, or whether that's the virus is getting more infectious or it's a different strain, or that it's getting less infectious than others, but that it's the behavior of those people that's leading to some people infecting lots and other people not affecting hardly any. And I think masks on both in this, the stylist and the client in this case are huge factors in that. And I think it's important for us to realize that there are a number of things we can do to reduce spread. It's not only staying in your home or keeping 6 feet, but that we can do some things safely.
Yeah,
You know,
wearing a
maybe
mask.
not Arrowhead, but
maybe
other
Arrowhead.
things.
Yeah.
And
Arrowhead could be a little bit of a challenge.
You know, the World Health
Whoa.
Organization kind of reversed their stance now recently. And before they were advocating just if you're taking care of somebody to wear a face mask, medical professionals, because they wanted to conserve PPE. But now they have certainly advocated for universal face mask wearing as well, even cloth face masks.
So let's talk a little bit about that for just a moment. So does that mean anytime I'm outside or anytime I'm around anyone, I should always have a mask on? Because we don't have masks on right now.
Well,
Go ahead. Come on, Hawk.
so again, I think the thing that we are going back to is how long are you going to be around that person? Can you maintain 6, 8, 10 feet? Certainly further is greater. And if you are in not a confined space, if you're outside, especially if you're outdoors and you're walking on the trails passing each other, your risk of infection is going to be very, very minimal. You probably don't need to wear a mask then. If you are at a pool, obviously we don't want you wearing a mask in the pool. But the more that you can distance yourself from other people and have less interaction, and especially in a confined space, you probably don't need to be wearing a mask. If you're going into Quick Trip, if you're going into the grocery stores, in those cases you probably do need to wear a mask for sure. But really outside, separated from other people, and if you do have any interactions or passing them, you probably don't need it. But in those other situations, certainly a mask is important.
So David, is this our new normal right now as far as where we're seeing the disease and the level of disease? Because it feels like we've probably hit this kind of equilibrium. We've been now at around 10 patients for the better part of a week. Society's reopening. We're seeing a lot of new cases. But is that just kind of going to be where we live? Because, when we earlier talked about reopening, I was going to guess 30, 40, 50 patients are going to be hospitalized, but we're around 10.
Yeah, I think, back to the sort of 3-week gap between seeing new cases related to sort of reopening or an exposure, and then even longer time before they're hospitalized. I'm still not sure we know. I think what we're seeing right now is really related to Mother's Day. And what we'll see the end of this week and next week is related to Memorial Day. And then in 2 weeks from now will be related to the protests and demonstrations. And so I don't know. I think you're right that we have recognized that there will be a series of next normals. Like we've reached one now for a week or so that's around 10. And I fully expect that there will be a bump, even in the hospital. I don't know that it's 30 or 40 in the next week or two, but I think that it's very possible that we do still see that, but that next normal will sort of change. We'll go for a week or two at a certain level and sort of live there, and then something else will change, and we'll go up or down from there.
Yeah, I'm going to make my own bold prediction once again, not based in science, but what Steve Seitz wants the world to look like. I think behavior has changed a lot And I think had we introduced some of these variables back prior to people doing the things we've been saying so much on the program, we would see a lot more patients. The other thing I think is if protests or bars or all these open events were inside, I think we'd be seeing a different type of patient population. And I think our strict infection control around nursing homes has made a huge difference. Because even when we see one patient get positive now, we're seeing one patient get positive, not an entire community become positive. I think that's just a big difference as well.
Yeah, I think that that's really key. The fear has always been that we would get to exponential growth where one person was infecting lots of people, and many of these interventions that we see have become sort of the new normal outside of the hospital. They are working. They have an impact.
We have helped ourselves.
It's really interesting. If you look across the country, right, at the national number of new cases, we have been at a plateau of more than 20,000 new cases a day for, I think, going on 40 days. It's a long time. I mean, we are in a stable period for new cases. Now, we may see this number of people in the hospital change as, again, people are younger.
There's a lot of different.
But yeah, if you look over the long run, we're really stable, and we have been really. We're not getting better, but we're not getting worse. And the question then is, does that sort of, that risk of up to 1,000 deaths per day, which is really the result of 20,000 new infections a day, is that range something that we can be comfortable with?
I think this is who we are for a while. That's kind of where I would land on that. And then the other follow-up to that, I think, is in Western Kansas, Central and Western Kansas. Some counties have not reported many cases.
Right.
They're starting to report more cases. Talk a little bit about what's going on in Central and Western Kansas and some of the counties. And why they still aren't seeing, a few have seen hospitalizations related to the meatpacking plants or nursing home, but by and large, not a lot of hospitalizations either.
Yeah. I don't have a great answer. What we know is we don't have a lot of data, and when we don't have a lot of data, it's really hard to give a specific answer. So I think that if, over the course of time, we really test more aggressively in some of those places, we are much more likely to find more cases. Although, I do think if we continue to be able to really isolate our nursing home populations well, it's less likely that those new cases result in large numbers of hospitalizations or large numbers of deaths. And I think those are all good things. So
Yeah, they are good things. Jill?
Regarding admissions, Allie wants to know, what do you think is going to happen in the fall?
Oh, in the fall, and we know that that's a more difficult time for
Yeah.
viruses in general. There's so many variables here.
Yeah, that's going to be interesting. So I think the first thing was we get to the fall, get your influenza vaccination. That's going to be important, number one, for protecting you against influenza and out of work time and hospitalization time. Hopefully all these measures that we're taking now with the increased hand hygiene, possibly even the mask if we're still wearing masks at that point, that will all have an effect, a benefit of reducing other types of respiratory infections, such as the common coronavirus, rhinovirus, things that cause the common cold, but also things that cause influenza. So overall, I think it would be great, and I'm hoping that we see actually less influenza infection this
More
coming
vaccines.
season.
Geez, did you really say less influenza vaccination?
No.
Come on now.
Oh, I correct myself. Less influenza infection, more influenza vaccination, and continue the hand hygiene, the mask,
I think
the social distancing, all that.
All the things
Yeah.
for infection control will impact our rate of
Right.
influenza,
Yes.
and I think keep us healthier. So if people can keep doing this, we've proven that it works. Now we already knew it works, but we've really proven to ourselves that it works.
Right.
So we just have to keep doing that. And so I think we can really be okay in the fall if we keep doing these things. Plus, there may be other therapies that come out. Speaking of which, any new therapeutic updates?
Again, so there have been some retractions for the hydroxychloroquine articles, but that was mostly based on access to data and mostly about the side of the adverse events of all that, not so much the treatment of the disease. So there's still more publications saying that hydroxychloroquine really doesn't show any benefit for treatment or for protecting you against it if you've come into contact with it. The remdesivir, obviously, we are still using. We do have quite a few doses here to give patients should they be sick, but I know that Gilead is going to be shipping out their last doses soon. Hopefully they are trying to ramp up production of remdesivir as well. And again, we are still working on other therapies as well, so that's kind of where we're at right now.
Thank you. So Logan is trying to help make me be better heard because Logan and Anthony are in the backside of the studio making things run. And I guess today I'm too quiet. And I wasn't even mumbling, which is what I use that sometimes. Okay. All right.
I may say this word wrong. This one's for you.
Okay.
Patty is afraid that she might end up on a ventilator because she has to have a bronchoscopy.
Bronchoscopy, yeah.
Okay, and a lung biopsy, and she wants to know, is it safe?
Yeah, that is a great question. We know that patients who have procedures who are COVID positive don't do as well as those that don't have COVID positive. And so that's why we screen every patient here before they have a procedure. A bronchoscopy can be considered an invasive procedure, especially if you have to have a biopsy. Fortunately, we test all patients prior to having a procedure like that, so we should know if you're positive or negative. And if you don't have COVID-19, if you don't have SARS-CoV-2, then the likelihood is you're going to be just fine, and I don't think you need to worry. I don't think you'll get it just because you're here. We do a really good job of those infection control prevention things, so I wouldn't be concerned. Make sure you have your screening test to know that it's safe. And once you've had your screening test, if it's negative, you're safe to go ahead and have that procedure done.
Okay, Rich is asking, and this one may be for you, Dr. Wild. The Johnson County dashboard shows ICU beds increasing from 50 to 80% from June 2nd to 6th. Is that significant?
Well, so they're increasing for a lot of reasons.
Right.
Mostly because people are reopening, they're doing cases, and we're back to having our routine patients in the ICU.
Yeah, I think those are all reasons. I actually had a conversation both with the Johnson County medical officer and the Johnson County EMS medical director about this, because you start to see those numbers increasing, and there's definitely a question or concern. No doubt, those are not due to a huge number of COVID positive patients in the ICU. So I think that's the good news here. It is really related to the other things that are going on. I will say, though, if you study that Johnson County AIMS, or their sort of tableau, their dashboard well, there's a section that shows the Johnson County positive census for COVID. And I looked this morning before I came downstairs. Johnson County has been at its peak with more than 50 positive patients in the hospital since May 25th and hasn't really changed. So that's more than even early in the disease process when we had a higher number of patients in the hospital. And so I think there's a lot, I'm sure, that goes into that. And so if the question is there some impact on COVID disease? Sure. Is it what drove the reduction in ICU capacity, or that increase in the number of patients in the ICU over the past few days? We don't have any evidence of that so far, and I don't think it's likely that that's the driver. It's probably these other things.
Yeah, and I think the next question or concern about it would be, if we've got 80% of beds utilized and we see a surge, are we in trouble? And that's a possibility, but we're not really seeing that surge right now, which is why people we've especially have reopened our operating rooms, reopened our procedures, because we believe we can handle the increasing cases. We have plans for changes again. I mean, if we do see that there's enough of a surge that compromises our ability to deliver ICU care, we'll go right back shutting down those things that take up ICU beds. But I think it's important to remember that people still need care. We can't stay shut down forever, and as a result, we go ahead and we open things up, understanding that we think we have the PPE, we have the capacity, we have the ability to flex up if we need to, we have the plans, and we have all the ideas and who's going to do what in place. So that ability to have closed down initially, even to great financial harm to medical communities throughout our country and right here at KU and throughout our city, that ability to close things down did a couple of things. It gave us, first of all, the potential to build up our ability to build up our PPE. It also gave us the time to work on what our plans were going to be. And you would think, well, how come we didn't already have those disaster plans on the shelf? We sort of did have a few disaster plans on the shelf, but nothing like what we were anticipating, and quite frankly, nothing like what we saw in New York. What happened in New York scared everybody. We all are much better prepared because of that event. I'm not trying to say that New York had to suffer like that, but I'm just saying we learned from watching what happened in there in Italy and China.
Yeah.
Nicole wants some clarification on why the hospital stopped taking temperatures when entering.
Why did we stop checking those temperature guys, Dana?
Yeah. Well, we know that the first thing that we've been doing is everybody has been in PPE. So we started masking all of our healthcare workers, also with eye protection, started masking all of our patients. We also started testing all of our inpatient admissions. And we understand that occasionally we can get some people who may come through and have a slight temperature of 100 degrees or more, and that's what the temperature cutoff we were using. But we know also that you can miss a lot of people from that. So because all of our healthcare workers and patients were protected with their own PPE, that is one of the main reasons that we stopped screening people, especially in the outpatient setting.
And David, we weren't finding a lot of positive screens. That's the other part of it. We do.
Yeah.
So I think that had to do a bit of an impact, and we're not sure it was valid.
Yeah, so I think if you look at the symptoms, the percentage of patients that have a specific symptom, fever is very common. It's 70 or 80% of the patients that are positive have a fever at some point in the course. But on any given day, it's maybe 25 or 30 or 40% at the most. And so that's why we weren't finding many. It was almost a false sense of security. The second piece I think that's really important to that is people need care, and many people, especially in the ambulatory space,
Yes.
as Dana mentioned, were coming here because they needed care. And because we put protocols and process in place to prevent spread, PPE, masks, all of the things, we're treating everyone like you could be positive, that risk of transmission had gone down. So for us, since we're preparing and planning and acting like everyone may have COVID, there wasn't a lot of benefit from that temperature screening. In other places where you're not treating everyone like they're positive, in businesses, for example, it's a great first line of defense. And so there's a little bit of a difference there. If the question is, I keep hearing that offices and businesses should check temperatures, why is the hospital not? That's really the key reason.
It's all about thinking that what you guys said. If we believe and treat everyone as if they have SARS-CoV-2, if they all have the virus, and we treat you that way because we make everybody mask, and we do the social distancing and all that, but really it's about the masks, then the temperature screening becomes less relevant because we've already got you. We're already acting like it. Plus, you're in a hospital, a lot of patients have fevers. So as a result,
Yes.
you had all these things, and we had all these workarounds. Oh, you have a fever, we got to send you to this special route, we do all these special things. Well, but the problem is, you see, you're in a hospital and everybody has a fever, that's what we do. And so instead, let's just make sure everybody wears a mask, and we'll treat you like you're sick.
Yeah.
And then we could follow our normal workflows around that.
And I guess the one other point of clarity I would add is we are still screening our physicians and employees and vendors with temperature checks and a process around that. So it's really patients that we're not checking for these reasons. Everyone else still has the same stringent level
And
of
if
screening.
we have a fever, we have to go home and quarantine. And I had my temperature check this morning, 97.4. Not quite an igloo, but it's getting there.
Brandon wants to know, as we increase our social bubble just a little bit, should we not go into our friend's house?
Okay, social bubble, that's a good one, Dana. And I have to say, I'm going to confess, I came in contact with a little more family this weekend. My daughter came down here from Chicago, made her check her temperature at the door, made her wear a mask for a while, listened to make sure she had no cough, no sneeze, no sniffle or anything like that. What do you think?
You may have to give her an MP swab test then.
I could. I thought about going to do a brain
she's
swab,
bad.
brain biopsy. Yeah, I thought about that.
I think that's important. That was going to be a point that I was going to bring up earlier when we were talking about the Lake of the Ozarks parties, the demonstrations, people opening up. I think as we get more opened up, people will start increasing the size of their bubble. Some people will do it quicker than others, but I think that will also aid in the spread of the infection. So I think it's going to be really important to continue to discern how you do that, how you go about increasing your bubble and interacting with people who you haven't been interacting with for the most part for the last 6, 8, 10 weeks. Again, there's no crystal ball, but that will have to be a very concerted way and thoughtful process of increasing your bubble. And that's really the only thing to say. Maybe talk with the other people about that.
Yeah, I got that same exact question. We had friends that wanted to do something inside over the weekend and wanted us to come along inside. And I said, I just asked, I said, can we keep 10 feet apart for the 6 of us that you're asking to be in the house? It was a small group. It was a group that I trust, but can we keep 6 or 8 or 10 feet apart? And the answer was, well, no, we'd be in different rooms in our house. And I said, well, then probably not. Why wouldn't we stay outside? Well, it's warm. Okay, I get it. I mean, first warm weekend, yeah. But there's definitely, I think that it's sort of a it depends question. If you're in a place where you can mask and keep 6 or 8 or 10 feet of distance, then maybe inside isn't as huge of a deal. But if it's someone's house and you're really unable to do that, then I would say think really long and hard about the risk that you're willing to accept.
I think, so I'm in a workout group, and this weekend we worked out, and you think, well, how can you do that safely? Well, we're on the size of a hockey rink.
Yeah,
So everybody had about
literally.
20 to 30 feet between them. You're outside, and the wind's blowing. You're like, you know what? I think that's really safe. And so I think it's all about the full dynamic of the area you're in.
Is it safe to travel by plane to California around mid-July? And this is from Robin.
You know what, Robin, I'll tell you what, we're going to answer that, but we're going to really get into summer travel tomorrow when Dr. Dana Hawkinson is back, as well as Dr. Wissam El-Trini, another one of our outstanding infectious disease doctors, and we're going to be hitting that safe travel question. So we'll give a brief answer today. We'll go into more detail tomorrow, Dana.
Yeah, it's going to be hard to tell how things are going to be in July, so we can just start there. Certainly we know that there is low prevalence, not as high as we thought it would be in general of the infection, but we know it's out there, so that's the biggest thing. And we don't know how much more it will be out there. There are things we've always advocated for driving over flying. If you have to fly, again, I think your highest risk is going to be in the plane itself for that amount of time. I think you can protect yourself at the airport. You're not going to be touching high surfaces. You get through the security line. You use your hand gel or you wash your hands. You try not to touch high-touch surfaces. Wear your mask. But I think the most risky part of that is in the plane itself, and we'll talk more about that probably tomorrow.
All right, so let's wrap up this morning, and let's kind of hit a couple of things. David, thoughts you want to send our audience out with today, and we'll go back and forth about good guy, bad guy once again. Here we go.
Well, I think, we've always said we'll know more in 2 weeks, and today I kind of said, well, actually, maybe it's we'll know more in 3 weeks. But every time we say that, yeah, we do come back with more understanding and information. I think I'll use this to piggyback just a little bit on how do you travel and what is safe. There were some observations that stood out to me in the understanding of how spread in the meatpacking plants in Kansas was likely to occur. I didn't realize they were wearing masks at the point of the outbreak. But one of the observations was that lots of the masks of the people working, and you could see this on a plane, they were working within 4 feet of each other, and people were wearing their mask below their nose, covering their mouth but not their nose.
That probably isn't going to help.
And I see that here as I walk through the hall.
Absolutely.
I see that among healthcare workers and people who are here in our hospital and stop and talk about, the point of the mask is to cover mucous membranes, mouth and nose. And so that's just a good example of there are a lot of factors that go into this question, some that are in your control and some that are not. And the behavior of people, individuals, but also the larger collective society, counties, states, whatever, is really going to determine what the summer looks like and what the fall looks like. And I think it's very possible, maybe even plausible, that we see a spike that we don't want to see in the fall. I don't know that I would necessarily say that I'm 100% on board with that being a must. It has to happen yet, especially because we've seen the impact of behavior change on the spread of disease in the past 2 or 3 months. And so that, for me, that's a very, very good positive. It seems like when we know what to do and people do it, we've been able to bend the curve, literally bend the curve.
But doesn't this mean that I was right about our bending the curve arguments? Are you going to give that up?
I don't remember any of those conversations.
All right, Dave, final thoughts. Had to work that in. Dave.
Final thoughts. Just again, we are getting into the time when people are going to be traveling more. I know that in Wyandotte County now, pools are able to open. So these things are going to be important. Continue to maintain 6, 8, 10 feet of distance if you can. That is going to keep you the safest. We're not worried about the virus dropping into the pool or swimming. It's really going to be your ability to stay away and in larger proximity or further distance from the people around you, and that's going to kind of keep you the safest.
This has been just, I think, a really informative stuff. I always learn a lot when I'm with these guys. They are really bright, and they do great work. The rest of this week, again, we're talking about summer travel next tomorrow, and then on Wednesday, social isolation and loneliness, the dangers of those things. And then mental health help for officers, first responders, and veterans as we look at the things around protests and some concerns around how we handle race in the United States. I think it's important to also look at some of the mental health aspects for first responders and the police. We've certainly delved into that last week around racism and mental health aspects, and we'll be getting into that toward the end of the week as well. We wanted to tackle that question about what's the mental health of first responders, police, and firemen like. That's a really important topic and something I don't think has been covered very well. So until then, remember, the basic pillars of infection control are what has bent the curve and will continue to bend the curve no matter how you get there. So until then, just remember, there's nothing like our music and there's no place like home.